Thank you, Dr. Valla. And Dr. Mahipal did show a very nice way to look into what you are going to see and what you are going to do it on the table also. I'm going to talk about the newer ways to do our capsulotomies. And we all understand we have graduated from a simple manual capsulotomy during the time of ECC IOL to a CCC, which was a mandatory for a phacoemulsification. Now again, lasers giving us a capsulotomy. So it is capsulotomy to capsulotomy. It's a full circle. But there are two ways to do a good capsulotomy, two lasers. And that is basically to look into a good rexus size, good orientation, and good stability of these rexes for during the surgery as well as the post-op period with IOL coverage also, and also looking for decreasing the incidence of a posterior capsular opacification. Those are three things. One is having a good intra-op capsulotomy opening for a phaco, good implantation, coverage of IOLs in the periphery, and decreasing PCO in these cases also. So we name lasers. We have a femtosecond laser, and Jepto in between it was there. Now we have a capsule laser. So these devices can give you automated capsulotomy in the anterior capsule when you are doing phaco in these cases also. This was one initial publication from our side where we compared femtosecond laser capsulotomy versus the manual capsule rexes in intumescent white cataracts. And we could realize in terms of sizing and circularity index wise, the femtosecond laser was much better than the manual capsule rexes. But the micro additions and possibility of tear extension was more in the femtosecond laser devices also. This new capsule laser device, which is a selective laser capsulotomy, is basically done after staining the anterior capsule deeply with trypan blue dye, and it absorbs the 590 nanometer laser energy, which gives you a photocoagulation of the capsule and opens the capsule in a very rapid manner where type 4 collagen gets into amorphous collagen material. So this is sort of a shrinkage of a capsule happening, and it is very, very fast procedure. So this study we looked into morphological feature of these capsulotomy opening in both femtosecond laser and the capsule laser devices also. It was done when I was in RP center last year, 40 eyes divided into groups, 20 cases each. Primarily, we looked into the size of capsulotomy achieved by these two devices. Secondarily, the coverage, centration, continuity, and the residual micro addition. In the post-op period, we looked for a day 1 and a day 30 in these cases also. The mean age was, as usual, 65 years plus minus 8. So there were two main intraoperative outcomes. One was how much was the micro addition seen in these cases. And if you look into the selective laser group, it was 2 eyes, that is 10%, and in femtosecond laser, it 11 eyes, around 55%. So if you see this particular small surgical beto, this is the capsule laser being applied after staining the anterior capsule with trypan blue dye. After having a good centration and the fixation, you can see how fast it was. It is less than 0.6 seconds, while the femtosecond laser, when you actually titrate, this is a white cat, you can see how much of sudden gust of the intracapsular fluid comes out, and it can cause micro addition sometimes also. So this is what results we saw. If you do a capsule laser, there's a definite shrinkage happening. The fluid leakage happens subsequently. Therefore, no blockage of a laser onto the surface of the capsule in these cases, which is not there in the femtosecond laser devices. The second was to see how much the size achieved by this capsule laser device. We initiated 5 millimeter target of capsulotomy, and in the post-op period, you can see this is immediate on the table. The size of IOL is 6 millimeter optic wise, and this is the cut of capsulotomy, which was 4.48 millimeter. So this was a slightly smaller size achieved after the application of capsule laser. Maybe there is a shrinkage of capsule happening in these cases, and the fixation and the distance from the laser to antechamber depth may make a difference in these cases also. The other important thing was to see the mean circulatory index, which was also almost similar in the two groups, comparable, and there was some difference in these cases also. This is how we measured the circulatory index in the post-op period. This is immediately after surgery. You can see the 360-degree coverage was there in both the groups, and the circulatory index was also similar in the both groups also. These are few important parameters where you look into two groups. This is the selective laser capsulotomy. This is the femtosecond laser. Microadhesion was much more in the femtosecond laser. The capsulotomy diameter was definitely better with the femtosecond laser, which we targeted 4.9. It came up to 5.03. The decentration of Rex is also very important, which is slightly more with the capsule laser devices. Visual acuity and the endothelial cell loss was comparable in both the groups also. To conclude, we do have now two laser devices, femtosecond laser, which is a very costly apparatus. While the capsule laser is, one-time investment, the device is attached to a microscope optics, and subsequently there are no costs involved in that. So it is a much more cost-effective way to look into. Predictability of size-wise, definitely femtosecond is more predictable, but as time graduates, you will have a much more improvement in this device also. The main advantage in white cataract, which we feel is, the laser is so fast and the release of fluid happens after the laser is completed. Therefore, there is no chance there will be extension of tear, which doesn't happen with the femtosecond laser, where you have an intumescence. As soon as you fire first few spots, the leak happens and the capsule dimension changes. That's why you have a more skip areas in the femtosecond laser. I think this device is to be, seen for future also. I hope that, this becomes much more applicable to all of us. Thank you so much.
Sir, but this capsular laser is not available in India.
No, it is there now. It is marketed by, My Healthscape group. And there are few people who already have these devices. One of the important group is the Pune group, where the Kelkar group, they are working on this. In fact, there is one international company attached with in studies, and where they are titrating this, because this is a device which seems to be foolproof for all angles. And the strength of a capsulotomy is much bigger than the femtosecond laser. In fact, it is 600 times stronger than the femtosecond laser capsulotomy.
What is the cost of this machine?
I'm not sure because I have no finance, but it is a one-time investment, and subsequently you have no investment required.
But sir, there is one Indian doctor. He's a very big innovator, Dr. Kakadia. He's also come with Laser-X.
Yeah. I think this is, once it attached to the microscope, only thing you require a good, Tapan dye, which has slightly more concentrated, and you have a uniform staining is required. Otherwise, you'll have a skip areas.
Exactly. I think there's a study also published on that where they compared the strength of the capsular X's, and they found this was the strongest capsular X's, followed by Zepto, followed by manual. And surprisingly, they found the femtorexis was weakest of all the four X's.
We all are aware.
And secondly, sir, I think you said your slide showed that there was about 0.3 to 0.4 millimeter shrinkage of the intended size. 5 millimeter aimed led to about 4.9,
4.78. Because this was our initial 20 cases. Okay. Now, after doing around 100 cases, we know how to achieve the good size of X.
Keep slightly bigger.
It depends on how effectively you focus the, your device onto the anterior capsule. If you focus little anterior, you'll have a smaller size. You focus little posterior, you have a nice size. So it depends how you focus your image, the Y-shape image comes in these devices. Okay. So we learn by our experience in this. Because it's a manual adjustment rather than femtosecond, which is totally automated the focusing.
Right. Thank you, sir.